for any family history of heart condition. S for smoking. Another S for
Good evening, everyone. How are you all? Again, welcome to First Aid AMC Clinical free 2-week session. So tonight is not my class. So today we are going to have a random role play session. So as I told you yesterday, that today Dr. Cynthia is going to take the session where you're going to learn about the exam scenarios. You'll be exposed to questions from all over the exam. And hopefully you'll be able to understand that how exam questions will look like, how how to do a new questions if it comes in front of your eyes, how to deal with those. So again, I know that this is a bit difficult for most of the beginners, but many of you are here who are our old student, and some of you are here who is in the middle of the preparation. So hopefully you should be able to come up and do some role play. Okay. So good luck, Dr. Cynthia. You can start, please. Thank you.
Hello, everyone. Hope you all are doing well. Yes, as Dr. Arshan said, today is our random roleplay session. In this session, we are discussing a couple of cases. Most of the cases similar to our AMC clinical exam cases. So basically, in your preparation, you need to take classes subject-wise, so like cluster-wise approach, and then in main exam you will get random cases. Okay, like few cases comes from medicine, then surgery, ONG, like um, all the topic in here. So in this random session, you will not get like cluster wise cases. You will get like, just a random case. So I would suggest just follow the cluster wise approach first, and then you will able to do that random role play. Okay. Um, so the beginner who are new for this course or who are just starting their preparation as a clinical exam preparation, my suggestion would be first start with your subject wise, that means cluster wise approach, and then and definitely like you should also listen that random role play session so you will understand how the exam cases is coming. Okay. Um, if you have any question, you can ask in the class. Um, in my class, I try to take 5 to 6 cases in every week. And most of the cases are coming very recently, like most of the time is similar looking cases. Okay. So who wants to perform today's the role play? You can write your name in the chat box and we can start. Um, so just a brief pattern of that random role play session. I'll give you a bit hints. Um, so you need to perform for 8 minutes. So initial 2 minutes it would be reading time, and then 8 minutes it would be performance time. Okay. In main exam, because that would be face to face, so you will be standing outside of the room, and outside of the room, you will get that stem of the case. And that time you need to think about the case, you need to read the stem in that 2 minute, and you need to think about all the differential. And when your 2 minute finished, and then you enter into the room and your 8 minutes begins. Okay. In that 8 minutes time, depend on the stem. For example, one case is given and the task might be history taking and then ask physical examination findings from examiner and then differential. Um, in that time, you can also able to write something in the paper. Okay. Um, And when your 8 minute finish, that means you need to exit the room and your next case will be starting, okay? But nowadays, good thing happen. Only you need to pass 9 cases. Um, so it is doable exam, okay? So let's start. Dr. Sarah.
Yes, doctor.
Okay. Let me share my screen first. So your 2 minutes reading time starts now, okay? Dr. Sarah, you get to start.
Okay. Hi, Sarah Jason. My name is Sarah, the attending doctor for you today. I came to know from the notes that you have chest pain. I will be with you, but I will ask some examination finding from the examiner. So please wait for me. So the examiner, I would like to know the general appearance of my patient. First, hair stability, sorry, like pulse, blood pressure, temperature, oxygen saturation, and respiratory rate.
So your patient heart rate 90 beats per minute, blood pressure 130/80, respiratory rate 18, saturation 98% on room air, and FI
90% hair saturation.
98% on room air.
98. Okay. 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 What is her general appearance? If she had any pallor,
No,
no jaundice, cyanosis,
no,
no puffiness, or any rash?
no,
Okay. So I would like to examine her neck if there is any increased raised GVB or carotid pulsation.
no,
Okay. Okay. No thyroid or neck lymph node.
no,
Okay, I would like to examine her hand if there is any pallor, any cyanosis clubbing, and capillary fill time, any signs of dehydration.
normal,
Okay, would like to examine her chest and heart for any by inspection for apex beat, any parasternal heave, and a chest movement with inspection and palpation for the apex beat, parasternal heave, palpable thrill or murmur, and will examine her chest expansion by palpation and auscultation of the heart, first and second, third and fourth heart sound, any galoprism, any murmur or any decreased respiratory vesicular breathing in associated ventitious sound, or and percussion for any dullness, and auscultation. Percussion for any dullness or hyperresonance, and also vocal firmness and vocal resonance.
So cardiovascular examination, you can appreciate there is a regular rate and rhythm, and you can hear mid-systolic murmur, best heard at the apex beat, no jugular venous distension or no peripheral edema.
Okay,
And
thanks.
respiratory sounds is clear on auscultation.
Okay, mid-systolic murmur. In the apex?
Yes.
Okay. And I would like to examine her abdomen as she's pregnant, 20 weeks by inspection for the symphysis fundal height, and if there is fetal movement visible, and any bulging or swelling distension, and the palpation for the symphysis fundal height congruent to the weeks of pregnancy, plus or minus 2 centimeter, and from the symphysis pubis. Also, I will palpate for any uterine tenderness, lie, and the position of the baby. And I would like to examine if there is any tenderness, abdomen or gardening rigidity, any organomegaly.
So abdomen is soft, non-tender, no organomegaly, no tenderness, and fetal height according to the gestational age. So fetal heart sound present.
Okay, so no lower limb edema or calf pain or tenderness, calf swelling, I mean, redness.
No.
No peripheral edema or vertebral edema.
No.
Okay. Okay, thank you. So I will explain the investigation to my patient.
You need to order first.
Order investigation. Okay, please. I would like to do Doppler lower limb for any DVT. Would like to do echocardiography. Would like to do basic blood test like CBC, LFT, RFT, thyroid function test, ESR, CRB, and I would like to assess her CTG and abdominal ultrasound for urine analysis, microscopy, and culture. Anyway, if she had no fever, so okay. She's pregnant, so she had no respiratory symptom, no chest X-ray needed. D-dimer, I can ask for D-dimer to exclude any pulmonary embolism, but she had no signs of DVT. Okay.
So the blood's examination unremarkable, and echocardiogram is showing mild mitral valve prolapse with mitral regurgitation. Otherwise, cardiac function and structure are normal. No evidence of pulmonary hypertension.
Okay, thank you. So I will explain the investigation. So Sarah, thank you for waiting for me. After this physical examination and investigation finding, I would like to inform you this from this report of the echo. It shows that you have some, the chamber. I will draw a picture for you. You know, our heart is two chamber above and two chamber below. One is above called atria and the below called ventricle. This mitral valve is between the left atria and the left ventricle. When this valve is decompensated, like if it is not functioning probably, we call like there is some widening or not improper function like mitral valve prolapse. This is what is shown in your echocardiogram. It means that some of blood regurgitated from the left ventricle to left atrium with each contraction of the heart. It is a manageable condition, nothing to worry about. We see a lot of cases like this. You are in safe hand. For the moment, you will be followed by multidisciplinary team approach. I will call the specialist cardiology. He will come and assist you, have a look, and do further investigation and assessment. You will be followed up by high-risk pregnancy clinic. You will need to be come frequently for antenatal checkups. Usually, there is no risk for the baby. We can expect some palpitation to happen, increased your heart rate, I mean. So if this happen, you will be managed with some rate controlling medication. Um, yeah, I will give you reading material about this condition, and I would like to review you after the specialist review. I will be following you with them, and if you have any query at any time, you are free to come to me. And yeah, we can give you some antibiotics if you are going for the surgery or during delivery, so to avoid any infection to the valves, because if the valve is sometimes we need to protect it during high risk operation, we need to give some prophylactic antibiotic to keep the valve working efficiently. Are you with me so far?
Yes, doctor. Anything else that I need to know?
Yeah, you will follow with your pregnancy clinic as well. You will keep eating healthy, balanced diet, avoid salt intake, and do regular exercise. Keep your dehydration
Your
balance.
time, doctor.
Thank you.
Dr. Sarah, very nice performance. So for the other candidate who listen, basically how you need to perform in this 8 minutes time. Dr. Sarah's performance was really nice. Few things she missed. Just I want to point those things out. So after reading the case, patient main complaint was chest pain. Dr. Sarah, when she started asking question to patient or examiner, she should comfort her patient first, okay? So she should offer pain medication to her patient. So she was missing that point. Then good thing she checked hemodynamic stability, because it's very important. Any patient coming with chest pain, that is category 2, okay? So you should make sure like you are checking hemodynamic stability of this patient. Um, and she did that one. That is really nice. Then she asking about all the physical examination findings, especially head to toe examination, because it's not a physical examination case. Your task is ask physical examination finding to the examiner. So few things you can improve. For example, Dr. Sarah asked me about some starting about hands, vital sign. She asked, then general appearance. Uh, but when she asked about cardiovascular examination, she asked all the like inspection, palpation, auscultation findings in one go. So in this way, examiner might miss something or you might not get answer from the examiner. So always try to ask highest 2 questions at a time, not more than that, okay? Uh, you all notice like when Dr. Sarah asked me about cardiovascular findings and respiratory, she asked me all the question at a time. So in this way, you might miss something. Okay, so don't do that. Um, you should ask like, what is the inspection findings of cardiovascular examination? Like, is there any scar mark, any previous cabbage, or any visible apex beat? Can I see it or not? Like in this way you can ask. And then palpation or like auscultation, can I hear heart sound, dual audible, can I hear any added sound, any murmur? Just ask in this way, okay? Respiratory examination, same. You should ask about inspection, 2 questions at a time, and then move to the next, like palpation, percussion findings, auscultation findings. Abdomen examination, again, like 2 questions at a time, not more than that. So when Dr. Sarah asked me, those were actually like very, it feels like rushing everything, but she asked at a time all the question. So in this way, she might miss something. And office test, she didn't ask me. The important office test in here is ECG. Your patient coming with chest pain and you are missing ECG, so that is the critical point, okay? Um, so the bloods investigation, your second task was you need to order investigation, then you will get the report and you need to explain to it to your patient. So when you order blood investigation, Dr. Sarah ordered blood investigation. That was really nice. She also ordered D-dimer, but she didn't order troponin, which is another key point in this case. Okay. Always remember, patient coming with chest pain, whatever the age is, you have to order troponin. And ECG is your key point. We are not doing chest x-ray because patient is pregnant. But if it is a very severe condition, depends on, like sometimes like specialists might ask about doing x-ray, but again, there is a radiation exposure risk. We're not doing chest x-ray. So in this case, like we can do all the blood test, ECG, and then echocardiogram, okay? Um, so basically all the diagnostic workups, so bloods and ECG, urine if you need it, and then fetal monitoring like CTG and echo. So based on the history, Sarah's condition is a mid-systolic murmur, like it's a mild mitral valve prolapse with mitral regurgitation, and you can explain the management plan. How Dr. Sarah explained the management plan? It's basically because patient already 20 weeks pregnant, it's the second trimester, patient coming with chest pain, you need to give symptomatic relief like analgesia for pain, okay? And then she already mentioned about high risk pregnancy clinic follow-up. That was fantastic. Basically, we are doing just a monitor with cardiologist and some lifestyle modification. You can advise some uh, risk factor for this patient and red flag as well. Okay, so that's the case. And how Dr. Sarah performed, that was really nice. After 8 minutes, you need to stop. That means like you need to exit the room and your next case will be starting. Um, so let's discuss our case. So Sarah Johnson, a 32 years old lady, presented to emergency department complaining about chest pain. She's 20 weeks pregnant and this is her first pregnancy. She described the pain as a dull ache that started about an hour ago and she denies any radiation of the pain, shortness of breath, palpitation or any syncope. She also denies any recent trauma, fever, cough, or upper respiratory tract infection. So your colleague did physical examination. Your task is ask physical examination finding from examiner. Then you need to order investigation. After that, you will get the findings. You need to explain those investigation to your patient and further management plan. Okay. So as I said, this is the physical examination finding from examiner, not the physical examination case. Okay. So starting, you can ask, so the introduction, you need to give a good introduction to your patient. Like you can say, hi, Sarah, I'm Dr. X. I'll be looking after you today. I can see that you are coming here for chest pain. Do you have any chest pain at this moment? If you have any chest pain, I can give you pain medication after ruling out any allergies. Okay, so that could be your introduction. And after finishing your introduction, then you can say, Sarah, can you please just wait for a minute? I need to talk to my examiner, then we'll come back. Okay. So examiner, I would like to know my patient vital sign. So you can ask about all the, either my patient is hemodynamically stable or not. So ask about blood pressure, heart rate, respiratory rate, saturation, temperature. Then ask about general appearance. How does she look like? Um, she's uh, she's in mild distress due to pain. Ask about her BMI. Then you can ask about cardiovascular. So you can ask head to toe physical examination finding to your examiner, but your time is limited. So based on the history of presenting complaint, so you need to improvise or you need to cut down your physical examination. Okay, you don't need to ask each and everything. For example, in this case, neurological examination is not relevant, so you can skip that one. Okay. So ask details about cardiovascular examination. So can I appreciate any irregularity of the heart rate? Then what about like inspection, any previous scar mark, any operation scar mark or anything? Then ask about heart sound, dual audible, any murmur, any added sound. Ask about jugular venous pressure. Okay. Then respiratory examination. So respiratory, I would just ask few things. I'm just asking about, can I appreciate any accessory muscle use or not? And then ERNT bilaterally equal or not? Any wheeze, any crackles? You should ask, okay? Then abdomen, again, I'm not asking everything, just I'll be asking very key point in here. So abdomen soft, non-tender, any organomegaly can I appreciate or not? Then ask about like fetal height and heart rate. That is the key point, fetal heart sound present or not. Then you can ask about lower limb examination, so any peripheral edema or not, okay? And office test, especially ECG for this patient. And ordering bloods, so always follow structure. So any patient coming with chest pain, we need to order bloods and imaging. So for bloods, ABC, EVC, CMP, LFT, you can order, and definitely troponin. You can order D-dimer if you are suspecting it could be pulmonary embolism, okay? And ECG. And as I said, like any patient coming with chest pain, usually we are doing chest X-ray, but in this patient, as she's pregnant, we are not going to do chest X-ray. She's also complaining like chest pain. We are not sure because she's pregnant. It could be any structural problem of the heart. Sometimes, like in emergency department, they can do bedside ultrasound, or we can order like formal echo. Okay. So those are the diagnostic workup for this patient. And as I said, this patient having a condition, we call it mild mitral valve prolapse with regurgitation. And these findings actually explain her mid-systolic murmur. So the management plan, and you can explain by drawing a picture. So during your 8 minutes time, when you start explaining to your patient, my suggestion would be try to draw a picture. That would be easy for you and your patient as well. Okay. So you can draw a picture and you can say like, look, this is the heart and there is a fourth chamber of the heart. Each chamber separated by a door-like structure. We call it valve. Okay. So what we are thinking, there is a leaking valve, and that's why like you are having these symptoms. And when I listen to your heart, I heard some murmur, okay, like abnormal heart sound. So at this stage, we are just doing symptomatic management. As you are having chest pain, we can give some paracetamol, and we can follow you up regularly. I can refer you to the cardiologist to monitor your that leaking valve. Okay. Some lifestyle modification also you can follow. You can follow regular exercise, balanced diet, like weight management, because patient BMI was 31. Okay. Um, and also because you are 20 weeks pregnant with that mitral valve prolapse, you can suggest like from now on, I can refer you to the high risk pregnancy clinic, and they will manage you as a multidisciplinary team approach. Okay. But you should reassure your patient that is usually a benign condition. Just close monitoring needed during this pregnancy. Okay. And your patient can go home with safety netting. You can provide the red flags. So that's the case. Dr. Shikha, you have to ask a specific question to your examiner. If you are asking to your examiner, doctor, I want to know about respiratory findings, then second question your examiner will ask, what do you want to know? Okay. So because your time is precious, so you can say like, I'd like to know about the respiratory findings, especially ERNT bilaterally equal or not. Is there any added sound, any wheeze, any crackles? Okay. So each and every time you have to be very specific to your examiner. Otherwise, your examiner will ask you again, what do you want to know? Okay. Dr. Sashi, are you there?
Yes, doctor.
Okay. So this is your case, and your 2 minute starts now.
Yes. Okay, doctor. I'm ready.
You want to start?
Yeah.
Okay.
Hi, Elizabeth. This is Dr. Zeskala, one of your doctors today treating to you. May I know what's the problem with you?
Hi, doctor. Today I'm coming for just pre-op investigation.
Okay. From the history, I came to know that you are having um surgery, right? You
Yes,
are having fracture in,
operation.
yeah. Since when you are having the fracture?
Fracture?
Yeah. When you are having the pain, since when?
Pain?
Yeah.
I don't have any pain, doctor. Just
Okay. Do you?
I'm having hip pain. You mean hip pain?
Yeah.
Okay. Yes, doctor, and that's why I'm going for that surgery.
Okay. Uh, do you have any history of fall?
I have a couple of falls in the last 1 year.
Okay. Since when you are having this pain, it's been since 1 month or the 2 months like that?
I'm having hip pain for a long time, doctor.
Long time. Okay, I'm sorry to hear that. Is it sudden or gradual?
It's a gradual onset.
Gradual. Okay. Is it continuous or intermittent in pain?
Coming and going.
Okay. Do you take any medications for that?
Um, just Panadol, doctor.
Panadol. Okay. Does it increase on in doing any work?
Yes, doctor, sometimes.
Okay.
Especially like if I'm walking too much, um, it is too much painful.
Okay. Previously, do you have any type of pain like this?
No,
No. Okay. Does your family have any type of fractures without fall or?
I don't know, doctor.
Okay. Do you take any medications other than Panadol?
No.
No. Okay. What about your BP or the diabetes? Do you have anything?
Yes, doctor, I have high blood pressure and not diabetes.
Okay. Um, I have seen your X-ray, Elizabeth.
Mhm.
I'm We are suspecting like cancer type of thing on your X-ray, but we are not sure about that. So that we
You
have
mean,
to
doctor?
take some sorry,
What do you mean?
like we are suspecting some type of abnormal lesion in your X-ray.
Okay, doctor, I'm coming here for just pre-operative investigation, and you're giving me like I'm having cancer.
No, we have suspecting, that's it. We need to take some other scans for that to make sure that there is no suspecting cancer or not.
That's really
Mm,
shocking news for me.
I'm sorry to tell that. It's not sure, so we have to take some CT scan or MRI to make sure that lesion is not cancer before the doing the surgery.
Where is the cancer, doctor?
It's in spine.
Okay.
Yeah. Um, so after findings, we can tell you about that. And for management, as of now, we'll be giving you the Panadol.
Okay.
So,
Anything else, doctor?
um, and we have to make sure that CT findings, and we will refer you to the orthopedic doctor for the surgery and other findings as well, and for the other treatment as well.
Anything else that I need to know, doctor?
Sorry, that's it.
Okay, no worries. You want to stop?
Yeah,
Okay. Dr. Sashi, I really appreciate that you are doing that role play. So what do you think? What's your performance?
it's not that good.
Um, do you have a study partner?
No, I'm just starting now.
That's totally fine. So my suggestion to you, just find a suitable study partner, and as a beginner, yeah, just follow all the structure-wise approach. Like, look, your first task was history from the patient. Okay,
Yeah.
and when you read the stem, look, your patient actually coming for a preoperative hip ortho, like hip surgery, like workup. And that
Yeah.
workup, when they did, and they found incidental finding there was a pathological fracture. So your patient is not aware of the fracture. You got my point?
Yeah.
So when you introduce yourself, then your statement, like opening statement, that should be different. You should ask your patient, how's your hip pain? Or do you have any hip pain at this moment? I can give you some pain medication if you do have. And then you start asking question, because you already know that there is a fracture, and you are suspecting about cancer. So as your job should be asking details history, like which you asked me, that was really good, like any fall, any trauma history. Then you should ask about like any loss of weight, any loss of appetite, any lumps bumps, like any cancer related question. Okay,
Okay.
so
Oh,
like all the history, and like history, so when you ask about history, so there is a structure for the history, like history of presenting complaint. Then you need to ask about differential diagnosis history. Then you should ask about some general health question and SADMA. Do you know that?
oh.
She? You should follow
Eh,
that one, okay?
okay, doctor. Thank you.
Okay, no worries. So let's discuss the case. It's a GP clinic. 58 years Elizabeth came for pre-op checkup, and pre-operative patient is scheduled. That patient was scheduled for hip osteoarthritis surgery. So, as a preoperative workup, patient already had a chest X-ray, which was showing there is a fracture in T5, that means thoracic 5, and radiologists reported that could be pathological fracture secondary to, it could be like suspected cancer. So your task is history from the patient, explain X-ray finding to the patient, and explain implication of findings and management. Okay. So, what could be the reason for that pathological fracture? When you just read this step in your 2 minutes time, my suggestion would be think about differential and think about key point in this case. What should not miss? Okay. So, differential diagnosis in this case, number one, it could be due to any trauma related, it could be due to secondary deposit or multiple myeloma, or it could be like osteoporosis. Okay. Those are your differential. So basically, it's one type of breaking bad news case. You are suspecting it's a cancer. Patient doesn't know anything, just out of nowhere, you are going to tell like you found there is a pathological fracture and you are suspecting cancer. So you need to follow that breaking bad news approach, like a spike approach, okay? Because history is your first task, you should ask history, introduce yourself, show empathy, ask about pain, because your patient going for hip surgery. So ask about how's your hip, do you have any pain in your hip area at this moment, you want me to give any pain medication. You can rule out any allergies and then give pain medication if your patient needs. Okay. Then ask about hip surgery when that is booked, any concern regarding that surgery. Now you can say like, do you have any, I'm going to ask you details question, okay? Because we did some investigation, and I need to know further about it, okay? So do you have any trauma, any fall recently? Do you notice any recent loss of weight, loss of appetite, any lumps, bumps around your body, any weakness or numbness of your arm or leg? How about your bowel motion? How about your waterworks? Then differential diagnosis. So pathological fracture, and if you're suspecting cancer or any secondary deposit, what this cancer coming from? So you have to ask about either is a chest, any like lung cancer, bowel cancer, you should ask. So for the chest, you should ask about any chest pain, exertional short of breath, any cough, any hemoptysis, then any tummy pain, alternative bowel habit, PR bleeding, any headache, any blurring of vision, dizziness, like any intracranial like space occupying lesion. Then any back pain, spine pain, you should ask. If your patient complaining about back pain, you should dig more, okay? Um, and then because osteoporosis is also one of your differential, so ask about diet and do you take dairy product, ask about patient is a vegan or vegetarian or not, then sun exposure, exercise, that is important, and then smoking, very important. Then past medical history, any family history, any previous history of cancer, that is also important, okay? Now X-ray, because X-ray report already given, so you can explain like, look, Elizabeth, we have done X-ray, and that X-ray showing spine of uh, spine. So do you know that spine is made of the lots of bone? We call it vertebrae, and that vertebrae placed one on the top of the other, and in between there is a space. So normally all these vertebrae should be equal height, but in your case, in thoracic 5 level, that vertebrae looks like fractured. Okay, and radiologists, they reported it could be pathological fracture, and they suspected could be secondary to cancer. Okay, I know that that is not a good news. I know it's very like shocking news for you. If you want some time, or if you want me to call somebody to be with you, I can call. But that could be one of the possibilities. Okay. Other possibility, it could be due to trauma, fall, osteoporosis. But I'm really concerned because of cancer. It could be any cancer related pathological fracture. Okay. So it could be due to lung cancer or other cancer like oral cavity cancer, nasal cancer, esophageal, thyroid, kidney, uterine cancer. If it's a female, male for prostate. Okay, and risk factor, because you do smoking, and also there is a family history, if any family history positive or any trauma. So you can mention those are the contributing factor. Okay. Um, So, what could be the complication? Um, as I told, the possibility could be nasty growth to organ or any plasma cell of the bone marrow. We call it multiple myeloma, or nasty metastasis of the bone secondary to cancer anywhere. Okay. If osteoporosis occur, the biggest complication can happen. You can have fracture with very minimal trauma. Okay. If you sustain a fracture at this stage, it might take a long time to heal. So those are the complications. Okay. Management not your task, but if management will come, you can say immediate management. You have to confirm the diagnosis by doing investigation, like all the blood investigation, CT scan, PET scan, MRI, if you want. And management, it would be multidisciplinary approach based on the diagnosis. Okay. So that's the case. So your first task was history from the patient, and after finishing history from the patient, just follow the second task. You don't need to present the history to your examiner. Okay. What does waterworks means? That means you need to ask about patient urine. Is there any burning and stinging feeling? Okay, and bowel habit question. Definitely, it can take time, but the issue is patient coming with pre-operative investigation. So my suggestion would be you need to make a good rapport with your patient because you are going to give a bad, like breaking bad news to your patient. So try to make a good rapport with your patient. You can say, just say one sentence, your surgery is booked or not. Do you have any concern regarding your surgery? Definitely, your patient will tell, no, doctor, I don't have any concern at this moment. Okay. But it's a, what should I say? It's a good thing if you are just asking like those 1 to 2 sentences. So in this way, you can make a good rapport with your patient. Okay. But again, as a beginner, sometimes you feel like you are kind of lost, like how far we can go. But to be honest, like in times, you will understand what question you should ask and what question like you can escape. Okay, because your 8 minutes time is really precious, and my suggestion would be just focus on your task. Okay. Um, Dr. Aryan, spike approach. So any patient or any of the case you need to present as a breaking bad news case, you have to follow spike approach. Spike is a mnemonic. So S for setting up the interview, like you need to also make your environment like empathetic way. Okay. Private, quiet room. You need to sit down, making eye contact to your patient, like that. And then P for like perception. You can ask your patient how much do you know, why we have done those investigation, how much do you know your condition, why we have done this investigation. Like you should ask your patient how much your patient knows about her condition. Okay. And then I for investigation, like what investigation you have done and what was the result, you can explain. And K for like knowledge. For example, like you can explain the things in a simple non-medical term. Okay. And check your patient understanding. And E for emotion or empathy. In between, like you need to observe your patient emotion. If your patient notice like she's crying, you need to give a pause, wait for at least 5 to 10 seconds, offer her tissue or like water, and ask her like, do you want me to cancel today's appointment? You want me to rebook another appointment, or you want me to call somebody to be with you, like that. Okay. So any of that breaking bad news case, you have to follow that spike approach. Okay. You don't need to mention about the surgery and like other surgery is going to postpone or not. You just mention as we have done pre-operative investigation, and that pre-operative investigation showed pathological fracture query for cancer. So we need to do further investigation prior to that surgery. Okay. Um, you have to mention the implication. So explain implication of the findings. So your findings was pathological fracture. You are not going to talk about hip osteoarthritis surgery. Your a task was explain implication of the finding. So you got pathological fracture and you are suspecting cancer. So you need to explain what happened or what complication can happen. Okay. Okay. So let's move to the next case. Dr. Divya, I'll tell you as a beginner what could be the study plan when I finish my session, okay? So let's move to the next case. Who want to perform? Dr. Sumaya?
Yes, I'm here.
Thank you. This is your case and your 2 minute starts now. You can start.
Hello, my name is Dr. Maya, one of the doctors here. It's really nice to meet you, John. So tell me, how can I help you today?
Hi, doctor. I'm really concerned about my father, who's being recently diagnosed with hereditary hemochromatosis, and um, he, he's requiring regular phlebotomy. So I'm concerned about my situation because I heard that really runs in the families.
Okay, I understand. I'm so sorry to hear that. I'm sure you must be really concerned. But don't worry, now that you're here, I'll try to help you to the best that I can. So can you tell me how has your health been lately?
I'm okay, doctor, so far.
Okay, and you said your father was diagnosed at age 55.
Mhm.
Anyone else in your family has similar condition?
Yes, doctor. I think my father's brother also having similar condition.
Okay, okay. And can you tell me if you're experiencing any symptoms lately, like any fatigue or joint pain?
No.
Okay, and what about any past medical history like diabetes or hypertension?
No, doctor.
Okay, and what about any shortness of breath or any chest pain?
No.
Okay, and this might seem like a personal question, but are you married?
Yes.
Okay, and do you have kids?
Yes, doctor. One kid.
Okay. Can you tell me, do you smoke and drink alcohol?
I do, doctor.
Okay, and how much do you drink?
Maybe 1 to 2 glass.
Okay, okay, and have you ever had any liver problems before?
No, doctor.
Have you ever had any, do you take any drugs or any over-the-counter medications?
No.
And have you ever had any liver function tests done before?
Uh, Not recently.
Okay. Okay, so okay, thank you. Can you tell me before I tell you about hemochromatosis, do you know what it is? Like, what's your understanding?
I don't know much about it, doctor.
Okay, so hemochromatosis is basically a disease of the liver, and like you mentioned, it is hereditary. So it means that it's a genetic condition where your body absorbs too much iron, and then it starts to build up in your organs like liver and the hearts and the joints. And it's inherited, but it's inherited in a inherited in a recessive manner. That means that both of your parents need to have the gene in order for it to be in the kid. Uh, do you know if your mother has any similar condition,
No, doctor.
or if she was ever tested?
I don't know.
Okay, and do you have siblings?
Yes, doctor.
How many siblings do you have?
2.
Okay. So basically, what we'll do is we'll arrange some tests to check your to test your genes. So one of the genes that we test for is called the C2H2Y gene. And like I mentioned, it has an autosomal recessive pattern. That basically means you need to have two copies of the same gene to have the disease. And that means that, sorry,
What does it mean?
yeah, so it means there's 1 in 4 chances of uh, somebody inheriting it. If in your case, for example, like your dad has hereditary hemochromatosis, so there is a 1 in 4 chance that you or your siblings might have this disease. So I'd recommend your siblings also get tested. That would be uh, that's what we will do. Do you have any other questions?
Anything else that I need to know?
Yes. So even the uh, we if the tests come back to have if you do have the gene, then I don't want you to feel scared. It's a common condition, and there are a lot of things available and a lot of treatment options available. Anything else that you would like to ask me at this point?
Anything else that I need to know about this condition, doctor?
Uh, your kids also, if your genes come back for hemochromatosis, your kids also might need to be tested. And don't worry, I will also give you some reading materials about this condition so that you can read up about it and refer you to the genetic counselor for the genetic test. And then I will arrange another visit to discuss those results, and then we will take it from there.
You want to stop?
Yeah.
Okay. Dr. Sumayan, nice performance. You still have 1 minute 20 seconds. So don't stop early. Try to explain. So have you noticed your third task was counseling? That means that you have to counsel your patient. What happened if your patient also that gene will come back positive? So how you are going to treat your patient? You should also give some advice. Okay.
Mm.
So coming to take a short history, how you took a history, that was really nice. You asked me about all the feature like fatigue, joint pain. That's really nice. You haven't asked me about skin pigmentation. That is, which is very common in this case. And then alcohol, diet history, you asked. That was really nice. Then coming to genetic risk, how you explain is a bit complicated as a non-medical person, to be honest. So try to be simple. And then, so counseling, when you notice your task is counseling, that means that you have to explain everything, like investigation, management, everything. So investigation, genetic test is the confirmative diagnosis, but your patient is concerned coming for routine checkup because father having hemochromatosis, you are going to do definitely genetic test, but are you not going to do any blood test for this patient like iron studies? So that is the another important investigation you have to do. Okay. And then all the, as I said, like management, what happened if positive, then how you are going to manage this patient. Okay. So let's discuss the case. John Smith, 42 years old male, came for a routine checkup, concerned about family history. John, at this moment, I understand you are coming here. You have some concern. May I know what is your concern today? So your patient will tell you, like, doctor, I'm concerned because my father having hemochromatosis, like, and I heard that it runs in the family. So what about my chances to have that disease? So you can ask like, John, do you have any symptoms at this moment, like fatigue, joint pain, any discomfort, any pigmentation of the skin? And then ask about, do you have any history of diabetes, liver problem, heart problem? Ask about alcohol history and ask also about diet history, any first degree relatives apart from dad having similar situation. Um, Physical examination not your task. So genetic testing, you can say like genetic risk, because it's an autosomal recessive condition. So yes, as your father having this condition, may I know your mother is also having this similar disease or not? If not, then your chances would be like one of your sibling will get like so it would be like 25% chances. Okay. And then first you need to do some first line blood test like iron overload. um, just you can mention I'm going to do iron studies, and then confirmatory testing, it would be genetic testing. Okay. So do you have any other sibling? Your sibling also needs genetic testing as well. You don't need to mention about all the gene. If you remember, that's fantastic. You can say like, I'm sorry for that medical jargon, but for hereditary hemochromatosis, we need to check C282Y and H63D. Those are the gene are responsible for that hemochromatosis. And basically, we are going to check those genes. Okay. And if you do have any siblings, so they should also go for that investigation as well. An additional workup, like all the liver function you have to do. Sometimes, like if liver function abnormalities, then second step would be liver MRI. Okay. liver biopsy, very like late stage. And then counseling and management. So what happened if genetic testing is positive? Don't worry because it's a manageable condition. You need to educate your patient about lifelong monitoring and importance of early intervention. Okay, so phlebotomy, you already aware your father went through that phlebotomy. That is the main treatment. We have other option as well, like avoid iron supplement, vitamin C as well, and definitely alcohol reduction because there is a risk of liver cirrhosis. And we are going to do further investigation to check for any complication like any diabetes, any heart condition, any liver cirrhosis like that. And as I said, your first degree relatives also should be screened for genetic risk as well. What happens if genetic testing is negative or heterozygous carrier? So you have to reassure your patient that is the lower risk of disease progression, but we are going to check like RNA studies if any abnormalities noticed on the blood test, okay? So the key point of this condition, you need to detect early like liver cirrhosis or cardiomyopathy. Genetic counseling is essential for family members, and also phlebotomy is the main treatment for iron overload. And you need to also advise your patient to avoid iron-rich food, okay, and alcohol. So that's the case. For beginners, is it too hard? I know, like first few days, it would be really overwhelming for you, but trust me, over the time, you will also get through it, okay? Um, so let's move to the next case. Who wants to perform? Dr. Ella,
Yes, I'm here.
this is your case, and your 2 minute starts now.
Okay. Okay, I can start.
Okay.
Hello, Michael. How are you today?
I'm not feeling okay, doctor. Feeling sick.
I'm so sorry. Will you please elaborate of what brings you here?
I'm having fever for last 3 days, doctor. I'm shivering, sweating. I'm so tired, doctor. I'm feeling like I'm going to throw up.
It must be difficult. Do you need to throw up? Do you need help for throwing up right here?
No, doctor.
Okay. I'll ask you a few questions and then we can take this further. So, since when have you been having this fever?
That's 3 days, doctor.
Have you taken any medications?
No, just paracetamol.
Okay, only paracetamol. Does it reduce with paracetamol?
It works, but just temporary relief, doctor.
Okay. The fever is continuous? Like, does it come down to baseline at any time? Do you feel that the fever is completely gone?
It's coming and going.
Okay. Okay, it's coming and going, but it goes at a certain time. Okay. Do you have any other symptoms? Like, do you have any urinary symptoms? Your waterworks are fine?
It also has reduced, doctor.
It has reduced. Do you feel any burning or increased frequency?
No, not really.
Do you have any cough?
Yes,
Or
I do.
okay, is the cough dry?
Yes, doctor. But
Since
some of them coming out
sometimes, okay. Since when have you been having this cough?
same time.
Same time. Okay, since 3 days you have been having this fever. As I can see, what else do you have with this fever? Like what are the other symptoms? For example, you've mentioned like chills and night sweats. Apart from this, do you have any other symptoms? You
Yeah,
have fever, cough, chills, and night sweat.
yeah, feeling
I'm
all.
so, I'm so sorry you're feeling that way. Okay. So now let me talk about some of your past history. Have you had any illnesses in the past? Anything that you had to go to the doctor to?
No,
Any long-term illness?
I was diagnosed with HIV. That was 5 years ago. Yeah.
Okay. Do you have any other like diabetes or hypertension or something that you take a medication for
No,
on a regular basis? No?
no,
Okay.
doctor, I'm fine.
Okay. Okay. And do you have any history of travel or any exposure to a place which was endemic with a disease with endemic with tuberculosis like disease?
No,
Okay, so you haven't traveled
no,
lately.
no,
Okay, okay, okay. Are you eating well?
no, doctor. I don't have any appetite at all.
Okay, your appetite has reduced. I see that you sleeping well?
No, because of the
Okay,
fever and shivering at night time.
okay, okay. You haven't been able to eat. Before this, did you eat well? Were you eating well before this episode of fever?
Before that, I was fine, doctor. I didn't have any issue. I told you.
Okay, you were perfectly fine. Right. Okay, so as we see that you had a history of HIV positive diagnosis 5 years back. Were you on any kind of medications for this?
Um, Previously, doctor gave me some medication, but doctor, as I said, like I was completely fine and I was just positive. I didn't have any symptoms, so I didn't take that medication.
Okay, okay. So have you taken this medication continuously for some time or you quit it at the start?
I took it maybe few months and I stopped it.
Okay, and then you have stopped it. Okay. Do you have any lumps and bumps on your body which you can feel? Any lumps?
No,
Okay. Have you had any generalized weakness or weight loss in the past?
I feel very weak now.
Okay, that is due because of this illness. Okay. Just give me some more time. I will take you further with I will advise you. This to me looks like an infection associated with AIDS. So let me see where this infection lies. Most probably, you might be having an infection, which is common with patients who are HIV positive. But we are all here to help you, and you are in safe hands. So we will try and see where this infection is. Since you have given me a positive history of cough, uh, it may be your chest which is infected, or it may be lymph nodes, which is common with patients of AIDS. And I would like to do certain investigations so we can rule out the diseases that are not there, and then we can see what we can do with you. So I would like to advise you certain investigations, which are I will take blood tests. I will take draw blood for CBC, KFT, LFT, CD4 count, and also I will do an APG on you. And um, apart from that, I will do your chest X-ray, which is very important. And also, I would like to do a routine microscopy test for you, along with the culture CS of the urine, so that we can see where your infection lies. And if we get a negative thing from here, then we can take investigations further. I guess that's all I can think of.
Anything else that I need to know, doctor?
Yes, you can. First of all, I'd like to tell you that we will help you with this. Currently, if we will check your vitals, and if you are stable, we can we will either admit you or we will send you back on antibiotics, and then you can follow us up for your investigations. Apart from that, we also suggest support groups which you can join, and for HIV. Apart from that, since we will have to find out with your HIV panel whether you are in the infective period or no, and your contract. Most important history would be, I'm sorry, I missed it. It was contact tracing. So, have you had any sexual encounters in the past recently?
I do have.
Okay. When was the last time you encountered this?
Maybe last week.
Okay. So was it the only contact that you've had lately, or you have had more?
More.
Okay. So can you remember each of them?
What's the point?
Precisely. This virus spreads through sexual contact. So we need to know how many people you have been sexually intimate with, which it'll help us to trace down. And that is,
Your time's up, doctor.
yeah, sorry. Okay, thank you.
Nice. Nice performance, Dr. Eva. Few points you missed. What do you think? What's your preference?
Yes, I didn't do contact sexual history. I didn't take, which was, and I didn't take, like, I got very nervous, so I
Yeah,
missed a lot.
but that
Yeah.
was really nice performance. Few
Thank you.
things are missing. I'll just point it out in history. Like, look, you asked me a very good question, like about cough, and then you asked me about travel history. But patient with HIV, chills, rigor, night sweats. So you missed the important thing in introduction. You haven't asked me about hemodynamic stability of this patient.
Right.
So that one is missing. And then, like, what could be your patient coming with sepsis feature? You're not sure because patient is febrile, chills, rigor, and background history of HIV. You are not aware of that vital stability. So you need to like find out what is the source. The source could be meningitis as well. Like could be.
Right. I
You
missed
didn't ask me
meningitis.
headache, right?
I missed meningitis. I missed so many infective
Exactly.
things.
So
Yeah.
you didn't ask me about diarrhea history as well. Like
Yeah.
you just asked me about P. Now coming to differential, you mentioned like infection you were thinking, but look, we all know it's an infection. Your job as a differential, you need to mention like because you are having fever and background history of HIV, so that infection it could be like I need to find out the source of the infection. The source it could be lungs, it could be urine, it could be like GI tract, it could be like brain covering like meninges anywhere. So I need to find out, and you have to tell all those of your differential along with like it could be viral, secondary viral infection as well, like any CMV. Also, patient who are having HIV, they are more prone to get like pneumocystic pneumonia, like those atypical opportunistic infection. And then you should mention those words like opportunistic infection, like those things. Now, coming to the investigation, good thing you already mentioned about ABC, chest X-ray, but you haven't mentioned blood culture. You mentioned urine culture. Your patient
Right.
is with fever 3 days, and you are not ordering blood culture. Is critical error. Okay.
Right.
So let's discuss the case. Michael Johnson, a 36 years old male, came to ED
Thank
due
you.
to no worries. Came to ED due to fever for the past 3 days, associated with chills and night sweats. His past medical history states HIV positive, diagnosed 5 years ago, not compliance with ART. So your task is take a history, differential, and investigation. So, as I said, first you need to introduce yourself and then ask about vital sign of your patient. you need to know your patient either vitally stable or not, okay? Then history. So HIV-related infection risk, what could be? We are not sure when was the last CD4 count, viral load. There could be history of opportunistic infection like TB, PCP, CMV, like those are the things. And patient also non-compliance with ART. So you should also ask about any recent travel history. So fever pattern and associated symptoms, you should ask about, tell me more about your fever, like history of presenting complaint basically. So ask about details, fever history, associated chills and rigor. Did you take any medication? Does it work? And associated symptoms like cough. If cough positive, ask about either is it dry cough or productive, and if blood coming out, and then ask about any nausea, any vomiting, any short of breath along with that. Then meningitis to rule out, you should ask about headache, photophobia, any neck stiffness. Then any like GIT related infection, you should ask about any abdominal pain, any diarrhea, and any AIDS question. So you should ask about weight loss, night sweats. Also, TB lymphoma patient can have those symptoms. So you need to rule out those things. Okay. And HIV patient can have also lymphoma. That could be kyphosis sarcoma. Lymphoma is common condition, so you should ask. And as I said, differential diagnosis. So life-threatening infection, you need to rule out first. Sepsis, it could be bacterial infection. So pneumonia, UTI, catheter related, but your patient doesn't have any catheter, so you can skip. PCP, very common. Patient can present with dry cough, hypoxia, ground glass opacity on CT scan. Meningitis, not an uncommon condition, so ask about it. TB, again, not an uncommon. You should ask about any exposure history. Then other possible causes like CMV, toxoplasmosis, any other condition. Okay, ask about details HIV. So as you are having HIV that was diagnosed 5 years, are you taking any treatment for that? When was the last time you see your specialist? And why you stopped that medication? Okay. You can ask about general health question and then sexual history. So look, rather than asking how Dr. Ella asks about when was the last encounter of sexual exposure like that, you should ask like, are you practicing safe sex? If your patient practicing safe sex, and are you aware of the risk of you spreading that virus? So you need to involve like contact tracing team to prevent that spreading of the disease. So you need to notify Department of Health. So your job is done. You don't need to ask like when was the last time. Just mention like, are you aware of that? Are you using any protection? If not, then you need to inform Department of Health Service. Okay. And then, as I said, investigation. So definitely it's an infection like sepsis, unknown origin. So you have to do all the basic bloods, ABC, VC, CRP, CMP, LFT. And you can also do BVG to do, like you have to know the lactate for the infection marker. And then blood culture, urine microscopy and culture. Okay, and for the HIV specifically, you have to do CD4 count, viral load as well. And for basically septic screen. So septic screen also comes with chest X-ray. And if you notice your patient having coming with sputum, you can also order sputum microscopy culture. And because recently there is a COVID as well, so you can do respiratory viral PCR. Okay. If those investigation negative, and if you're suspecting say it could be meningitis, then your patient might need CSF analysis like lumbar puncture. Okay, and you can say all the viral serology as well. Management not your task, but if management will come. So initial management, if you're suspecting it could be sepsis, so definitely fluid, IV fluid. After collecting all the blood sample, you can start broad spectrum antibiotic and then monitor bloods. based on the actually your diagnosis, then you can keep treatment, and you need to involve your senior as well. Okay. And definitely talk to ID team about this patient, and they will come review the patient, and they might start immediately ART as well. Actually, we don't have that CMV toxoplasmosis specific question, but you can ask like anybody sick around, and CMV, because those are the kissing virus. So you can just ask like, do you have any close contact that the person having any glandular fever or anything? And CMV infection patient might present with diarrhea as well. Okay. But that is actually vague symptoms. So yeah, that's the case. Any question for this case? Okay, so let's move to the next case. No, you are going to inform Department of Health, okay? You can mention like if your patient is not our like he should follow that like those rules. You can say like you are having unprotected sex and background of HIV, so it's my legal duty to inform Department of Health Service, okay? Yes. I- You need to inform your patient that you are going to inform Department of Health Service. Okay, let's move to the next case. Um, any new candidate wants to perform? Dr. Abdul,
Yes.
okay, this is your case. 2 minutes to start now. Mhm. You can start.
Okay. Hi, good morning. My name is Abdul, one of the doctor. I will be looking after you. So, how can I help you today?
Hi, doctor. What's wrong with me, doctor? What's happening?
Uh, uh, Sorry to hear that you have been going through all these. So, I just need to ask the examiner. So, examiner, can I have the recent sets of vital sign of my patient?
What do you want to know?
So, I want to know the blood pressure, pulse rate, temperature, and respiratory rate of my patient.
So blood pressure 90 by 60, heart rate 110, respiratory rate 18, saturation 96% on room air.
Okay, thank you, examiner. So, examiner, based on this finding, it seems like my patient is hemodynamically not stable. So, I want to transfer this patient to the recitation cubicle and will continuously monitor his vital sign. So, I can see that the patient IV has already been opened, so that is good. And so, look, sorry, I forgot to ask your name.
Janice.
Janice, okay. So look, Janice, I understand you had a car accident, and we did all the required scans and tests. So that shows that you had a few fracture on your ribs, and also there was a laceration or tears in your spleen. That's organ within your tummy, and can you please tell me a little bit more about the pain you have? Where exactly is the pain?
That's my tummy, doctor. It's
Uh,
all
uh,
over.
all
So,
over.
yeah.
Okay. Do you feel short of breath as well?
Yes, doctor.
Oh, okay. And any bluish discoloration have you noticed on your lips as well?
No,
Okay. Can you talk a full sentence?
no. It's just your patient having a bit distress.
Oh, okay. Okay. So, and also with this, I'm just assessing whether if there is any flail chest. Uh, Uh, and also because I'm checking for the sign of pneumothorax, I'm checking for the sign of hemothorax, and also I'm checking if there is any internal bleeding. So I'm checking. So with that, I will quickly. Jenny, can you please stretch out your hands quickly? I'm just checking pale palmar crease, and also I will check the capillary refill time where I will squeeze the nail and see how quickly it goes back to normal. It shouldn't take more than a second. And now I'm checking. So I did check the pulse. Obviously, I checked the vital sign, which is not, it seems not stable. And now I'm going to check. So I can see there is a fracture or trauma site on the side of your chest. And now I'm going to see how your chest is moving with the respiration. So so with the rib fracture, I'm assuming that this will not be symmetrically, and there will be asymmetry of the chest movement. And now I'm going to just put my hand around your chest, and if you can just
Doctor, stick to your task.
okay. Okay, so look, Jenny, so the possibility here is, as I mentioned, it could be internal bleeding because you had a trauma to your abdomen and also to your chest. Basically, multiple rib fracture can or damage your lungs as well, as we call this pneumothorax, that the air can get stuck into the space where the lungs will not be able to expand or work properly. And also, there is another possibility that the ribs can lacerate the lungs and then can bleed internally, and the lungs will not be able to work properly, expand. So that we call as hemothorax. That could be another possibility. And also, you had a spleen laceration. So there could be internal hemorrhage, like means the spleen is tears, and that can bleed into your abdomen, and that can give you also a lot of pain. And that could be another possibility. In even there could be a possibility that your kidney might be injured, and if that is the case, then you might be having problem with passing pee. And if you are having any catheter, then we will be able to see any blood coming in. And also your tummy will be swollen, and your neck vein will also be distended if that is if your lungs or even if your lungs have any hemorrhage or bleeding inside or any ear trap inside. Or maybe in the worst case scenario, that could be damage to your heart as well. Sometimes that can happen as well. We call it a cardiac tamponade. So based on what you're having, like you have respiratory problems, so because your respiration is you are in distress, you have a little bit cyanosis. I can see bluish discoloration around your lips. So that could be another sign. And also you cannot talk full sentence. And also I can see that your saturation at the moment it's okay, but it's still low. Importantly, your blood pressure is quite low. So that's mean there could be underlying bleeding or any serious things going on. So do you have any question, Janice?
Anything else that I need to know, doctor?
Okay, so the things that what we will do is we will I will inform I will consult or liaise with the surgery registrar, and then we'll ask him and we'll explain your situation that this we have done this, and further if there was anything else. So at the moment we will do some blood tests. So we will take blood and we'll do blood grouping, cross match, blood group on hold in case we need that. Maybe you will need blood transfusions. We will do that, and also we will do some routine blood examinations. We will check your lung function. We will also check your urea creatinine. We will check in also we'll check your electrolytes, and also we will also check your kidney function. We will check as well. Mm, and yeah, so then once you become a little bit stable, because at the moment your breathing is not properly well, your blood pressure is too low, you feel dizzy, and also you can't breathe properly. And so we will monitor you closely until the surgery registrar is coming to just make sure you are in stable situation.
Okay, your time's also up. Dr. Abdul, nice try. Few things, very good. You checked about vital sign of your patient at the beginning, and you notice your patient hemodynamically unstable, and you already mentioned about how you're going to manage. That's nice. I'm not sure, like suddenly then you lost your track and you start because your task was explain the possibility to the patient. Okay, that means that you don't need to ask any, like, it's not a history pattern question, like you are going to ask one to two, like one by one question to your patient. You have to explain the possibility to the patient what's going on, and in between you can ask question to Janice, like, Janice, how you are feeling, do you have any pain, I can give you more pain medication, like in between you can ask, but it's not a history taking case. And then, like, you start doing physical examination that is also not relevant in this case. And look, hemothorax, pneumothorax could be possibilities because that there is multiple refracture. But when you asked about hemodynamic stability, you notice your patient saturation, respiratory rate fine. Main issue is blood pressure and tachycardia. So something happened, like either like patient volume or like loss happened, like hypovolemic. Your patient. So could be bleeding. So in this is the case of splenectomy you need to talk about because patient is spleen already lacerated and now patient further deterioration, like his condition is deteriorating, sorry, her condition is deteriorating, so you have to call surgical team again. They need to come and they need to take the patient to the theater for possible splenectomy, and counseling, that means you need to talk about all the splenectomy things.
Yeah.
Okay,
Okay, yeah, understood.
so let's discuss the case. 30
Okay.
years old, no worries. 30 years old female met with an accident. Another car crashed into her car from side and patient was retrieved. Brought to the ED, primary survey done, reviewed by surgical team, and that CT abdo found there was a multiple refracture on the left side and also having spleen laceration. And surgical team decided to manage conservatively. But 3 hours later, patient complained of increasing pain and you are asked to review the patient. Observation chart given inside the room, patient lying on the bed with drip running. So your task is explain the possibility to the patient and counseling accordingly. So in here, uh, so when you introduce yourself, just introduce, hi, Janice, I'm Dr. X. I'll be looking after you today. I can understand that you are here. You can just mention your patient had an accident and having that multiple refracture spleen laceration. But I just came to know that you are also having increasing tummy pain. So do you want me to give more pain medication? Just offer more pain medication for your patient and then ask your examiner about vital sign at this moment. What is the vital stability of your patient at this moment? Okay, if you notice like patient hemodynamically unstable, then you need to give like resuscitation, like follow DRABC protocol. Okay, because drip already running, but if you notice like patient also blood pressure dropping, tachycardic, the either you have to give bolus fluid or you need to also check either any bleeding inside or not, and then you need to give like blood transfusion, depends. So what could be the possibility in here? As I said, check stably vital sign is the key point in this case. And then mention if unstable, follow DRABC protocol, like um, IV cannula, take blood sample, example like ABC, UVC, blood group cross match, clotting profile, blood sugar level, and you can give fluid, but already mentioned drip running. So you can say like we can give some bolus, okay? And hook your patient to monitor because you need to continuously check your patient vital sign. Then talk to your patient Janice. You can say like Janice, there could be multiple possibilities about your situation. I can give you some pain medication first, okay? What I noticed like from that observation chart, it seems like your blood pressure is falling down and your heart rate is going up. I'm a bit concerned about you might lose some blood. Okay, so I attached IV cannula, took blood sample, start you on fluid, and I also call my senior to come and have a look. Okay, let me assure you that you are in safe hand, and we'll try our best to give you best possible care. Okay, so because you are thinking that could be bleeding, bleeding could be from anywhere in the body. Like it could be injury to the lung, spleen, or any blood organ, body organ, or any blood vessel. But we have done CT scan, and that CT scan of the abdomen is showing injury to the spleen, which I'm suspecting you might have that bleeding from that spleen area. Okay. And you also have refracture. So from that refracture point of view, we are doing just conservative management unless symptomatic. So just the pain management for pain with painkiller. Okay. And you need to monitor either your patient having short of breath, decreased saturation, or increased respiratory rate, cough, or other sign to rule out pneumothorax. Okay. And then because you're suspecting bleeding, so you need to mention like your senior might come and they will take you to the theater and possible there is a possibility of splenectomy. So you can explain spleen is an organ that is located in your tummy and is a part of our immune system. It has multiple roles. You can explain. One of the role it helps fighting infection and bugs. Okay, and it is prone to injury during any blunt or peritonic trauma to the tummy. Okay, um, so what we have noticed, like as we noticed, there was a spleen laceration. So our surgical team reviewed you, and their plan was conservative monitor. But after 3 hours, as you are having increased pain and your blood pressure dropping, so I'm suspecting bleeding from that area. Okay, and that's why I already called my senior. They will come and probably they will take you to the theater for immediate removal of the spleen. We call that name of this procedure is splenectomy. Okay. You have to talk about splenectomy. So surgery is either keyhole or it could be open. And don't worry, it will be performed under general anesthesia by experienced staff. Okay. So any surgery, there could be some complication like infection, bleeding, injury to other structure, risk of anesthesia. But don't worry, it will be done by experienced staff. So complication will be unlikely. Okay. And what could be the long-term management? Because body can live without spleen, but as it helps to fight infection, so you will be at high risk of catching infection. Okay. For that reason, we will give you vaccine every yearly or 5 yearly. Okay. And then you will be on antibiotic as well to prevent any infection. You will be staying in hospital for a couple more days and you will be seen by the specialist as well. Do you have any question? Just ask question in between, okay? So that's the case for post-MV accident and splenic laceration. So Dr. Saira, your task was explain possibility to your patient. It's not your physical examination, it's not a history taking. So you don't need to do any of those. You have to explain the possibilities of your patient condition. Okay. And you need to ask examiner about vital sign. So that's all for today's class. So I understand it's really hard as a beginner. So my suggestion would be as a beginner, go through your handbook. I know like sometimes the handbook is really boring, but the handbook has some handbook will give you some idea like what should not be missed, like key point, critical error. And there is also like important cases in handbook, at least I think more than like 80 cases that are coming last couple of years. So my suggestion would be as a beginner, don't miss those questions, okay? Um, So try to read handbook cases, important cases. Try to have a look how to take a history, what is the structure of that history, then physical examination findings, and then differential diagnosis and your management. Um, if you're going through that handbook, you will get an idea of, as I said, like key point and critical error. Okay. And after that, for that cluster-wise approach, so Dr. Arshan class will give you idea how to, so that would be subject-wise cases. And for subject-wise, like for example, medicine subject, you will get also cluster-wise approach, like tiredness cluster, abdominal pain cluster, chest pain cluster, like that. In cluster-wise approach, that will be really handy for you. And it will give you like all the differential you need to remember. Okay. So as a beginner, just follow those theory class. And in that theory class, you will know all the cluster-wise approach, okay? Try to make a note because when you finish your course, and it will help you during that revision time as well. And our session, like that random role play session, that's how you will get uh, cases in your main exam, okay? So in main exam, case will come randomly, okay? And those are the cases that coming last few years. I try to discuss, and in that case, if you are more than welcome to perform with me, and I encourage like most of the student to perform because it will overcome your anxiety and you like definitely you might do some mistake, and you can learn from your mistake, okay? Uh, so handbook, then your theory session and random role play session. I think that's enough um, for your MC clinical. And for the topic, if you're not sure, like you can follow some guidelines as well. For example, up to date, and then ETG for antibiotic guideline. Um, yeah. So those are the guideline. You can also follow some for peers. You can follow RCH guideline and some GP. There is RSC GP guideline as well. So for the latest like management, you can follow those guidelines. Okay, but in our course, like we try to yeah, update all the latest guideline, so you don't need to worry about the notes as well. Um, I don't suggest to go back all of your theory like AMC theory. It's not like that. Like it's a clinical. Um, so that's really good. Like you have all the like fresh memory from your MCQ. But remember for that MCQ, you have to pick like one answer. But in here, clinical is also your communication skill as well. How you are going to communicate to your patient. Okay. Yes, that is AMC Clinical Handbook. Any question for today's session? I know it's really overwhelming for beginners, but trust me, over the time, you'll also get through it, okay? Many of my students they passed their clinical exam in first attempt, so definitely it's doable. And I also passed my exam in my first attempt. So after MCQ, just have a solid preparation at least 6 to 7 months, okay? And try to find a good study partner and do role play as much as you can. There is no alternative rather than role play, okay? Some people prefers to like just read along, but in this MC clinical, as I said, it's mostly your communication skill and how you approach to your patient. So find a good study partner and perform role play. Okay. I know sometimes it's really hard, especially like as a beginner, there is lacking of confidence. So my suggestion would be as long as you have structure, you know the structure, like how to take a history medicines topic, how to take a history like PITS topic or ONG topic, because those topic actually having different structure, okay? And also like psychiatric history, how to take it. If you're like, if you have that structure, I feel like you are welcome to perform, okay? And this is the platform like you are allowed to do mistake, okay? So don't worry, if you do have uh, something wrong, then I can pick up and I can tell you, and you can remember the things in this way. Okay, so that's all for today. Feel free to ask any question in the group, and I'll try to answer. And see you in my next class next week. Thank you, everyone.